between Karnataka branch, which has an open mind, acceptability to the new technology, and advancing dermatology in the country. No wonder that we have for many decades, most of the leaders in IADBL coming from Karnataka. So thank you, Dr. Manjunath, and everyone, Dr. Venkat, Savita, for inviting me to speak on this. And thank you, Sharad, for an excellent talk. It was just engaging and very, very simplified. I know it must have been difficult for you to bring it down, the level of information so that all of us can understand what is machine learning is. So in next 20 minutes, I will no conflict of interest so far. I am collaborating with Sharad, but I have no financial involvement in this. So I start with Sundar Pichai, who spoke that AI is probably the most important thing humanity has ever worked on. AI is more profound than electricity and fire. That's really a very, very strong statement coming from Sundar Pichai. It carries a lot of meaning for us. So there are two types of thinking which have been described in psychology. The type 1 thinking and type 2 thinking. Type 1 thinking that comes naturally from the part of the brain amygdala, which is an emotional thinking, which is a primitive thinking. All other animals who don't have a developed frontal cortex, they also have that kind of thinking. It is an intuitive thinking. We need not to do a lot of exercise to reach to a decision in our day-to-day life. And most of our decisions come from this type 1 thinking. Type 2 thinking, or the slow thinking, that comes from cerebral cortex, and it needs a lot of effort. So every week we have a case conference in every Saturday. I observed a very, very interesting phenomenon. So all 30-40 people sit in a room and we observe a patient, we see a patient, we examine a patient. And intuitively, whatever first diagnosis we make, interestingly, we start discovering features, other features which are not present in that patient, imagining. So actually I see what mind wants them to see. For example, if a patient comes and our first impression is lichen planus, suddenly the hyperpigmentation present in that patient become violaceous, and vice versa. If a patient comes with lichen planus and the color is violaceous, but we haven't thought of lichen planus in the first impression, we appreciate that violaceous color as hyperpigmentation, not as a violaceous finish. So this is what compromises our diagnostic abilities in some instances, in some circumstances. It's still, after a certain level of experience, the intuitive thinking works very well in majority of the patients, in majority of the skin conditions. But that's not always the case. So here the AI can help, because AI doesn't have emotion. Humans have a lot of emotion. So now emotionless AI can make an objective diagnosis, and humans who carry a lot of emotion and type 1 thinking, intuitive thinking, can deliver a healthcare model where there is compassion by the humans, emotions by the humans, and objectivity by the AI or the machine. So this combination works very well in clinical practice. Unfortunately, there is a lot of resistance and a lot of denial in many dermatology circles, and that is not because AI is bad. That is because the regulatory mechanisms in our country are not really well implemented. So the source of anxiety comes from that corner, not from the implementation of the AI. I will discuss more about this. So Sharad has largely covered, but I will just speak in a minute about the pattern recognition in AI related pattern recognition model and its impact on healthcare. Now, in most of the specialties where the image or the visual of a patient is very, very important for the diagnosis, the AI plays a very, very significant role. And these are radiology, pathology, including dermatopathology, retinal imaging, and that is, as Sharad said, that the first app which has been approved by FDA is related to retinal imaging, dermatology diagnosis, dermatology dermoscopic diagnosis, precision dermatology, I will discuss this later on, and endoscopic diagnosis. So there is one common thing here is that all these subspecialties or the specialties have image or the visual impression as the first step in making a diagnosis. So with Sharad, we did a lot of work on this, and ours is the first multi-disease model which has been tested in clinical setting. So as Sharad mentioned that the initial research is mostly on the, that is in silico research, that is on the computer. The sensitivity is also calculated only on the computer, specificity, accuracy, everything on this. It is in silico experiment. But the real challenge is testing that model which has been developed on the computer in real life. So that's what we have done in a large number of patients, and it is not just me or Sharad, it involves a large number of our contributors in this. I will come mention their name later on. So this is the flow chart, how we did it. We included public database of annotated images of 40 skin diseases and normal skin, and private data was contributed by a good number of dermatologists, and some of them like Sanjeev Gupta and other people who have contributed in this. And there were total 12,350 images for training and 3,068 images for testing. And we kept the testing images and training images separate so that we come to know the real accuracy of the app. And then this app was tested by physicians and compared with dermatologist diagnosis. And we tested in all three settings: rural health care, and in Jhajjar, AIIMS has an outreach facility in Jhajjar, so we tested it there. In urban private practice and in urban tertiary care hospital, only the AIIMS was involved in this. So as you can see, the majority of the patients who were tested were from AIIMS itself. So this is in silico result of our app, and here you can see that there were some diseases which were performing very well and some diseases which were not performing very well in silico experiments. So these are the conditions which had very high sensitivity in diagnosis: normal skin, tinea unguum, melasma, rosacea, vitiligo, acne, seborrheic keratosis, fixed eruption, alopecia, tinea pedis, herpes zoster, melanocytic nevi, hidradenitis, molluscum, tinea cruris, and tinea corporis and tinea faciae. These had very high sensitivity. Some had very poor performance, and the main reason for poor performance was perhaps the lower number of the training images for which the app had been, the machine had been trained. So these include milia, candidiasis, melanoma, pityriasis versicolor, viral warts. But these figures changed dramatically when we tested in clinical setting. I will come to that. So these were the three clinical settings, and we tested the app, and this is how the app works. So when you feed an image in the app, it provides three options and with probability. For example, the image on the right, it shows it's an squamous cell carcinoma. So 88% chance of it being squamous cell carcinoma according to the app, and keratoacanthoma 0.09%, and basal cell carcinoma 0.2%. Now look at the image on the right. This patient came a few weeks ago to us, 2 weeks ago to us, and the diagnosis was, as you can see, that there is a scar and there is healing at one end and progression at the other end. So naturally, all of us would diagnose it either as cutaneous tuberculosis, like lupus vulgaris, or chromomycosis. But AIIMS was very confident it being squamous cell carcinoma with 92% probabilities. So AIIMS makes many foolish mistakes, but not when the probability is more than 90%. In any such circumstance, the diagnosis is generally correct. So this turned out to be squamous cell carcinoma. This was again 2 weeks ago in the Saturday case conference. Now we have these days we are having virtual case conference. So Dr. Ramam shared this image and asked us the diagnosis. My diagnosis was AC dermatosis, overlap lichen planus pigmentosus. Now the AB diagnosed fixed drug eruption. So actually it was a case of generalized fixed drug eruption. So there are most of the time I beat the AB in its current form, but there are instances when AB beats me in many such cases. Particularly when we have only an image, we don't have the history, we don't have the interaction with the patient, we don't have palpation, chance to palpate the lesion. And in such cases, I think only image available, then AB performs reasonably well. So this is the accuracy of diagnosis in 3 settings and overall. So combined accuracy was 75%. Urban private practice had the highest accuracy, and tertiary care had as expected, the slightly lower accuracy. So now overall sensitivity remains the same as was in silico model testing, but I will come to some detailed results in my next slide. So in this, this actually represent the individual disease performance. So here the green dot represent the top 1 sensitivity, that is the top diagnosis when we consider only the top first diagnosis. The blue dot represent the top 3 sensitivity, and the line connecting between these two is the sensitivity difference between top 1 and top 3. So as you can see that some diseases which perform very well here is hidradenitis suppurativa, basal cell carcinoma, vitiligo, acne, alopecia, molluscum contagiosum, melasma, ichthyosis, tinea, squamous cell carcinoma, psoriasis. But here you can see that the size of the dot represent the number of patients. So you can see that larger dots, they are clustered on the top, means high sensitivity. So those diseases which are common, the AB performs better. Those diseases are uncommon, the AB doesn't perform that good. And this is because the same ratio is also there in the training images. So AB is as good as you have the training images, the number of training images. However, there are some exceptions. One is eczema, here you can see, and the other is melanocytic nevi. These two had a fairly good number of the patients, but still the sensitivity was low. And the reason behind it was, I will come to it later on. And this is the confusion matrix of top 1 prediction. So these are the actual numbers, and these are the predicted classes. So if this is a heat map, so if the colored code is distributed along the diagonal line, this means the app is performing very well. So here you can see that in top 1 sensitivity, these figures, they represent the percentage. For example, 89% of the patients in acne were correctly diagnosed as acne. 88% of alopecia were correctly diagnosed as alopecia. However, only 57% of anogenital warts were correctly diagnosed. 93% of basal cell carcinoma were correctly diagnosed as basal cell carcinoma. 45% of the Bowen's disease were correctly diagnosed as Bowen's disease. So this is how the heat map shows, and this is for top 1 prediction. But if you see top 3 prediction, these figures go very high. 97%, 96%, 71%, 97%, 54%, and so on. So I think a lot of success depends on the patient data. If we have more and more number of images, and if we have a good model to train the machine, the performance improves. So the coming to the accuracy, as I told you that eczema was often misdiagnosed as psoriasis, lichen planus, and tinea. Melanocytic nevi were sometimes misdiagnosed as pigmented BCC. Tinea, manna, and pedis were sometimes misdiagnosed as psoriasis and eczema. Bullous pemphigoides, lichen planus, eczema, and pyoderma. These were the troubled areas in our app to start with. Now the performance has improved further. So then we thought that we should validate in biopsy confirmed cases. So in this, the most interesting was that there were 19 skin cancers and benign 109 lesions. And in biopsy confirmed patients also, the top one sensitivity was even better for skin cancers, 84%. Top three sensitivity was 100%, means the cancer was identified in top three differentials in all patients who had cancers. So the app performs very well in cancers, skin cancers, but doesn't perform so well in inflammatory condition as we have seen in previous slide. So then we also compared the performance of app with non-dermatologist physician. 10 such physicians were involved in the study. So here this assessment 1 and 2 by dermatologist, 2 was every time the patient was shown to two non-dermatologists. So this was their sensitivity. Both of them were having 50 and around 40%, while app top one sensitivity was around 75%, and top three sensitivity was nearly 90%. So in this heat map, again, you can see that lighter color in non-dermatologist diagnosis and darker color in app diagnosis, suggesting that app performs much better as compared to non-dermatologists. Now, dermatologists may get upset about it, but in a large rural areas of the country, there are no dermatologists. Dermatology is much in demand branch, and most of the dermatologists are located where there is enough income or more income in urban areas or cities. So most of the patients in the rural area, they are treated by those non-dermatologist physician, primary care physician who have very little training in treating dermatology patients. So possibly we need to train those people using AI so that they refer the patients whom they cannot manage in primary care early in the course of the disease. And we don't see those patients who have come after a significant time lapsed and the disease has become complicated. So another study we did was basal cell carcinoma study, in which we compared the performance of machine versus non-dermatologist versus dermatologist. This was a Google survey form. So we provided the images to the physicians and surgeons, and there were 36 dermatologists, 14 non-dermatologists. Out of them, there were 9 general physicians and 5 surgeons. We did not inform them that it was a BCC-centric survey, and the 58 images belong to the BCC and 48 images to non-BCC. So, and this is the accuracy. You can see here 85% with the machine, 65% mean with the dermatologist, 54%, 54.6% for surgeons, and 43% for non-surgeon, non-dermatologists. So general physicians. So you can see that machine, when it comes only image inspection, in a photograph, machine outperforms in cancer screening. There is no doubt. There are many studies from different parts of the world, and it has been repeatedly proved that when it comes to skin cancer, machine outperforms dermatologists. Then we also developed did a study on COVID-19 in silico validation of this. And this model was done, this algorithm was done, and what we found that the sensitivity and specificity of COVID-19 rash, we clubbed all kind of heterogeneous manifestation as one single category of COVID-19 skin disease, and what we found that 84.2% sensitivity and 99% specificity when it comes to COVID-19 rash. So it looks very heterogeneous to us, but if we train the machine with all kind of manifestation as a single category, machine is able to pick up the that particular class. So this is the first study, a proof of concept kind of a study in this kind of situation. So it's just some of the interesting cases I picked up from this from internet, from a Facebook page. And here you can see that I would make a diagnosis of tinea interdigital in this kind of patient. However, the app detected it correctly as psoriasis as first possibility and tinea pedis as second possibility. Then sometimes it makes error even in a very classic case. Like for example, melasma, it couldn't diagnose with confidence as melasma. So we have developed a kind of new system in which a collage instead of single image is fed in the machine and the app. And this we have also submitted for US patent, Sharad and all of us together. So here you can see that the probability improved from for melasma from 29% to 54%, and it could be able to diagnose the melasma more confidently. And similarly, in this patient, this is actually a DLE case, but when a single image was fed, because the most representative image may not be available when we treat, or we may not choose the most representative image. So again, when we put a collage, it correctly diagnoses discoid lupus erythematosus. So it improves, the performance improves. We are still testing it, and we still don't have the data. So we also did a review of literature quickly. I'm finishing in the next 2-3 minutes. This is we scanned all the literature, and we found there were only 3 more studies apart from our own study where more than 10 diseases were included, and none of these studies, they were tested in the clinical setting. So and our mean AUC was 95.95, which was quite comparable to Han et al. Study, which is the Google study, and the mean top one accuracy of another this study was 57.3 and 55.7, which is quite low. Liu et al. Had 71% sensitivity. Mandis et al. Had 78% sensitivity, but this was not tested in the clinic setting. We have to test it in the clinic setting, and you can see that our results were not very different in silico study and in clinic study. However, individual diseases perform very differently. Some diseases which perform very well in silico model, they did not perform well in the clinic, and some diseases which perform very well in the clinic did not perform very well in silico model. So there is some discrepancy, but overall result remains the same. And apart from this, the CNN can be used in dermoscopic images, and again, it outperforms dermatologists. These images are much more controlled because they are clicked from the dermoscope, and invariably the AI model perform at par or better than dermatologists in dermoscopic images. And another very important area is dermatopathology. Now that this whole slide scanner system is available, the dermatopathology is on the verge of complete automation. So this whole slide scanner scan the whole slide, and then this can be used for AI training as well as AI prediction, and this is possible. But most of the studies are having just binary diagnostic classification, that is differentiating malignant from benign, and there AI outperforms dermatologists. However, we need to do a multi-class diagnosis system in dermatopathology if we really want to implement it in practice. That is still far in the future, and unless we have a good database of histopathologic images, this cannot be done. So I don't have time, I think. My time is over. Dr. Manjunath?
You could carry on for another 2-3 minutes, fine.
Okay, just 2-3 more minutes. So there is another area which has AI as an application, and that is precision dermatology, or the also known as when we treat a patient, we treat on the model of one size fits all. That is, we don't take into consideration the genetic or other aspect of the patient. We see a patient with psoriasis and we prescribe what is recommended for the treatment of psoriasis without taking into consideration the patient related data. So the current era is we are moving from this kind of approach, like one size fits all approach, to precision dermatology, where each individual patient deserves a tailor made treatment. Now, this needs a lot of laboratory workup like omics and other studies, which is not possible. So here, this topological data analysis by artificial intelligence, by the machine learning, can help. Now, in this study, instead of measuring transepidermal water loss, which is a very complex and cumbersome procedure and also expensive, the equipment is expensive, these researchers, they assessed only skin barrier function by image analysis of the skin surface. That is a magnified image, and it was very close to what transepidermal water loss studied in a through the routine method. So the AI can actually help in individualizing the treatment. It can detect with confidence the filaggrin mutation by just examining the magnified skin view. So this is, a revolutionary thing for advanced dermatology, and this can be this is the future of dermatology. So I think I will not go into the teledermatology, because in real life situation, we machine has only the image analysis in the current form. As Sharat said, that the history and other data can be integrated in the machine analysis, but it is still in the early stage. And so machine has only the photograph to analyze, but we have many things. We take the history, we examine the patient, we palpate, we feel, and we have our own intuitive skill. So what happens in teledermatology? In teledermatology, most of the time when patient or another physician sends us the data, it is only the image data. So this is the true comparison of an AI algorithm and the physician's performance. So here you can see that in all teledermatology studies, whichever have been done in US, the machine outperformed dermatologists, and this was more profound in the screening of melanoma. However, there is a word of caution here, that there was one meta-analysis and which said that some of these smartphone apps are not really usable in their current form in the clinical practice, and their validity is still doubtful. And that's why many of them have CE approval, but none of them have US FDA approval so far. So I will skip this, but we did a quick survey of 166 dermatologists in India to know the acceptability of AI. And what we found, that a significant greater percentage of older dermatologists, more than 35 years of age, as compared to less than 35 years of age, perceived that AI will benefit dermatology. So it is quite counterintuitive. Generally, the technology is welcomed by younger people and not so warmly welcomed by the older people. But here it is entirely different, and that's why, because many of the younger dermatologists, they have an apprehension because they are still in their early career, and rightly so, that they feel that if the AI comes and if general physicians take away their bread and butter patients, then they will have trouble. But let me tell you that India is a country of 1.3 billion people, and we have some 10,000 odd dermatologists. It will never be the case. So there are enough for every dermatologist, enough patient load for every dermatologist. Maybe in the beginning that one can struggle, but not as you grow older. So and most of the young people, they felt that AI should not be a part of the training in dermatology. Older dermatologists felt that it should be a part of training. And dermatologists aged less than 35 perceived more often that AI may replace dermatologists in future. But older dermatologists, they felt that AI cannot replace dermatologists in the future. So it was an interesting thing. And the most important here is that the question, in response to question whether AI is boon or bane to dermatology, nearly half of the respondents, they said that they don't know, they can't say. So still a lot of uncertainty in this field. It is still coming up, and but I am sure the things will be much clearer and less apprehension. There will be less apprehension among dermatologists. Now, in a paper on national strategy for AI issued by Government of India, it was recognized that there is a great scope of AI to tackle the current disparities in quality healthcare across the country. And the issues of ethics, privacy, and security in AI were also discussed in this paper. However, this is from our own article, which we have submitted in IJDVL. However, there was no comment on stringent regulation on the use of AI for the healthcare sector, as is the case for other countries. So we are still, early in this. So I must tell to our young colleagues, young friends, that it is man versus machine. It is not men versus machine, it is men plus machine. As I told you in the beginning, that our decisions are often governed by emotions, and the machine's decisions are often governed by objectivity. So if you are a solo practitioner and if you need another opinion instantly on a patient who is sitting in front of you, it is AI, where AI can help. So thank you very much for your attention, and I must appreciate, apart from Sharad, Vikas, and Jyoti, and many of our colleagues, Dr. Rashi helped me a lot with this, and thank you very much for your attention.